אוקיי, שומעים עכשיו? כן, נראה לי שכן. אז ברוכים הבאים לכולם. Welcome everybody. I will switch to English. I'm very glad to open our conference about the unobtrusive therapist, contemporary variations on therapeutic presence that is beyond interpretation. And especially, I'm glad to have with us here today Dr. Robert Grossmark, whom I will present in a few moments. This conference is a celebration of the beginning of our new academic year at the Winnicott Center, our 8th academic year. And I would like to invite Dr. Meir Steinbock, the co-director, to say a few words.
טוב, צהריים טובים. אני ככה אדבר בעברית, אני נתתי לרוברט את הטקסט באנגלית. טוב, חשבתי ככה לומר ברכה ועוד משפט. אז ראשית אני רוצה לקדם בברכה את כל מי שבא לכאן היום. לאחל שנת לימודים פוריה ליותר מ-70 תלמידים חדשים שהצטרפו השנה למרכז. לתלמידים הממשיכים, לצוות המורים והמדריכים המסורים והנאמנים שתורמים מהידע והניסיון שלהם בהרבה אהבה ושמחה. אני רוצה לומר תודה ענקית לענת בדר, מזכירת המרכז, שמחזיקה את כל המפעל הזה על כתפיה. וכפי שכולנו פוגשים את זה, היא עושה את זה ברוח טובה ובסבלנות אין קץ. ותודה מיוחדת לרכזים ולצוותי הניהול של התוכניות השונות. כמובן לברך את דוקטור גרוסמרק ושאר הדוברים ולאחל לכולנו יום עיון מעניין ומלמד. עוד משפט על מה שצפוי השנה במרכז. השנה אנחנו מתכוונים להרחיב ולהעמיק את מרכז ויניקוט כסביבה מקצועית אשר תאפשר לצד העמקת החיבור של החשיבה הויניקוטיאנית לקליניקה, מפגש מעשיר ומרתק עם זרמים מרכזיים נוספים. השקנו השנה את בוקר ויניקוט, שפתוח לבוגרי המרכז ומוריו. זה יהיה מפגש קליני בימי שני בבוקר, אחת לחודש, שימשך כ3 שעות, בו יובא מקרה קליני ויערך דיון בהנחיית אחד המורים על החיבור של הקליניקה לתיאוריה. אנו משיקים השנה במסגרת לימודי ההמשך של המרכז קורס דו-שנתי בשם זוויות מתחלפות, שמיועד לבוגרי תוכניות מתקדמים, וכמובן בוגרי תוכנית המתקדמים של מרכז ויניקוט. את הקורס ירכז אבנר ברגשטיין. השנה הראשונה תוקדש ללמידה של עיקרי החשיבה של ביון, והשנה השנייה תוקדש לדו-שיח של אבנר עם מורים שמלמדים ויניקוט במרכז. דו-שיח שיאפשר, אני מאמין, העמקה בכתבי ביון וחיבור לחשיבה הויניקוטיאנית. כמו כן, נמשכת זו השנה השנייה במת שעטנז, בה הפסיכואנליזה פוגשת זרמים שונים בתרבות, תוכנית קורס שיערך בריכוזה של חגית אהרוני, בהשתתפות יואל פרל, אפי זיו, חנה פרונט, צ'רטוק, משה ברגשטיין ותמי פולק. אני מאחל לכולנו שכל העשייה הזאת תמשיך להתקיים. אני מקווה באווירה הטובה, הפתוחה, שמאפיינת כל כך את המרכז. מאחל לכולנו הנאה בכנס היום. תודה.
Okay, I will say a few words about the subject, about the structure of this day. And perhaps first thing, I would like to make a mutual contract with you about the English, because I want to be allowed my mistakes and you to be allowed your mistakes, if you have any. I mean, we would like to have your participation, and no matter the English. So I would like to relate to the phrase therapeutic presence that is beyond interpretation. Interpretation, like other psychoanalytic concepts, has multiple meanings, radically different from each other. So when we say beyond interpretation, we have to indicate what meaning we are referring to. I would say that the meaning implied in the name of the conference is of interpretation as an intervention aimed at gaining insight. One can, of course, disagree. Antonino Ferro, for instance, wrote in 2005, "In my view, the concept of interpretation should be extended to any verbal or non-verbal intervention capable of generating transformation. This is the broadest definition that I ever met. I think that such a broad definition may blur the varieties of therapeutic technique. There is a difference between the therapist's presence when he is like primary substances, air and water in balanced conceptualization, and his presence when he aims at the patient's understanding something with his mind, with his intellect. There is a difference between a technique that is based on knowing when we work in areas where mentalization is a fact, and the technique that is based on being and experiencing in Masoud Khan's conceptualization when we work in areas where no mentalization exists or just, okay. Hopefully, we all work in a mixed technique, to borrow an expression from the field of art. Hopefully, we can flow flexibly during the session between these modes of therapeutic presence in harmony with where the patient is. And this is not as simple as it sounds. And yet, for many encounters with students and supervisees in recent years, especially the younger professionals, like MA students in clinical psychology, who are the future professionals, I realized that the mainstream in psychodynamic education is still emphasizing the need to interpret in the sense of gaining insight. This is why it seems there is a need to bring non-traditional technique to the fore and have it discussed, which I hope we are going to do today. A word about the structure of the conference. In the first session, Dr. Grossmark will give his lecture, Enactment with Total Situation, which will be followed by a free discussion with the audience. In the second session, which will be chaired by Smadar Steinbock, 2 lectures will be given on the subject of the day. They will be followed by a discussion with Dr. Grossmark and the audience. And these lectures were not written as discussions of Dr. Grossmark's work. In the third session, which will be chaired by Chayuta Gurevich, a detailed case will be presented and will be followed by Dr. Grossmark's discussion and a discussion with the audience. Now a few words about Dr. Grossmark. He teaches and supervises at the New York University postdoctoral program in psychoanalysis, the National Institute for the Psychotherapy's program in psychoanalysis, the Eastern Group Psychotherapy Society, the City University of New York Clinical Psychology doctoral program, and the University of New Mexico Medical School. He co-edited 2 books, The One and the Many, Relational Approaches to Group Psychotherapy, and the other book is Heterosexual Masculinities, Contemporary Perspectives from Psychoanalytic Gender Theory, and is currently working on the forthcoming book, The Unobtrusive Relational Analyst, Working with Difficult-to-Treat Patients, to be published by Routledge. He has published numerous psychoanalytic articles, among them The Unobtrusive Relational Analyst and The Flow of an Active Engagement, which maybe some of you could see. We sent a link to this paper. Dr. Grossmark is an innovative and creative writer within the relational school, emphasizing analytic work with patients whose ability to relate to another is limited or non-existent.
Thank you so much. Thank you all for being here today. And I wanted to thank, before I start, I wanted to thank everyone who made it possible for me to be here and for this whole event to happen. So of course I want to thank Michal, who has really made it happen. And I wanted to thank the conference committee, Meir, Smadar, Yossi, Hayuta, and Nomi. I feel very well taken care of and very welcomed here. And just on a personal note, it's very meaningful for me to be here at the Winnicott Center today. You know, I live in New York for 30 years, but I am British. I grew up in London. And so for me to be at the Israel Winnicott Center is a moment of personal psychic integration for me. So I'm growing as this event takes place. So the paper is called Enactment, the Total Situation. In a sequence of papers, I've tried to outline how an unobtrusive but deeply involved and present analyst can engage with the flow of enactments and companion the patient into the lived experience of these non-verbalizable states and ways of being. And in this paper, I will summarize and continue this work. I will propose that alongside enactments of trauma and early object relationships, we might consider a register of the incarnation in the treatment dyad and the field of total situations as outlined by Melanie Klein and later applied to the transference by Betty Joseph. I will suggest that Klein's concept of total situations invites a vector of understanding of analytic process and enactments that can bring the totalistic nature of the patient's internal world and unrepresented states to life in the field of the treatment. I will describe a case in some detail that captures these ideas, but first I would like to explicate the concepts of the unobtrusive relational analyst, psychoanalytic companion, and hermeneutic regression, I'll explain what that is, before returning to Klein and Joseph's description of total situations. Following the relational turn, we now comfortably regard psychoanalytic process as a mutual and egalitarian endeavor. While this mutuality is not symmetrical, the contemporary relational psychoanalyst now uses expressions of his or her own subjectivity with a freedom and creativity and is not silenced by the arbitrary constraints of abstinence or neutrality. Psychoanalytic process is viewed as hinging on the interaction of the subjectivities of both psychoanalyst and analysand, and as embedded in complex social and historical contexts. The relational turn has privileged the centrality of enactments that involve both the analyst and analysand, and the progress of many relational treatments often hinges on the emergence and resolution of these enactments. While all of these transformations have enabled so many of us to breathe more easily as psychoanalysts and work with creativity and engagement, we have also come to ask about patients who are not so able to engage in a dialogic interaction and who barely recognize another self or subjectivity in themselves or in any others, including the analyst. These are patients for whom there is little or no self or object constancy, for whom there are few alternatives to merger and the loss of self in human interaction, for whom sadomasochistic object relations predominate their every interaction, and for whom space, time, and reality are simply not experienced in a cohesive, ongoing manner. Such patients have chronic experiences of emptiness and fears of relational impingement. I think the case I will give you will capture what someone like this looks like. I'm also here referring to patients who are able to engage with what can appear to be intersubjective vitality. They can appear quite related, but they may also harbor self-states that contain earlier undeveloped and unspeakable parts of themselves. Such states, as Philip Romberg has so forcefully described, are sequestered and encrusted due to unbearable shame and envy. Such areas of the self or self-states are often chased underground, as it were, by a psychoanalytic treatment that puts a premium on relatedness, thought, and dialogic exploration. Right, we don't want to lose these less formulated and less developed parts of the self by going to the mental part. So in looking for a way to work with such patients, I found much that is useful in the work of the British Middle School, in particular the work of Michael and Enid Ballant, who along with their colleagues were interested in these more undeveloped parts of the self. As Enid Ballant says, before I was I. Michael Ballant observed how the recommended treatment of his era, that was in the 1960s, placed great premium on the giving and receiving of interpretations. And he lamented that many patients did not seem to benefit from this approach. He noted that for many patients it was the relationship itself that was paramount for the treatment to progress. And furthermore, he observed that regressed patients seemed to require a form of relatedness that was, and I quote, more primitive than that obtaining between two adults, wherein words do not function denotatively. He recommended that the analyst recognize and be with the patient, and be unobtrusive and ordinary, by creating and maintaining a treatment environment in which the patient can experience a benign regression. The parts of the patient that we would now call unformulated, in the words of Donald Stern, or non-represented, can find expression and reside in the treatment space. Ballant was explicit that such experience cannot, need not, and perhaps must not be expressed in words. See, that's such a challenging psychoanalytic idea. Must not be put into words. For fragmented patients who do not have a sense of self and object constancy, such forms of ongoing relatedness can allow the emergence of an indwelling of the self, a floating in one's own subjectivity, to quote Sheldon Bach, and the capacity to be alone in the presence of another, in the words of Winnicott. The treatment becomes the human place in which the patient is becoming whole. You can all hear me, okay, yes? I am clear? Good. The core of Ballant's unobtrusive position seems to be, I quote, recognizing and being with the patient. The orientation of the analyst is to create a space, a relationship that the patient can utilize, can mold and expand in his or her own idiom and psychic language. The analyst lends him or herself to the patient's primal process and allows the patient to regress and to use the treatment and the analyst in the most primal and unrelated manner. A patient may use the setting as a primary substance and float in the realm of the treatment as a person may float on water. In such states, the patient has no concern or consideration for the object, whose work is to have no separate interests from the individuals, and simply be there and be taken for granted. It's a very different way of being a human being. Such processes can only be disrupted by attempts to understand or talk about the interaction, or by acknowledging the analyst as a separate subject, by simply reminding the patient that there is another human being in the room. Now, to think about my idea of psychoanalytic companioning, and I use Winnicott here. Winnicott emphasizes that the mother and the young infant come into meaningful relationship with each other, and I quote, when the mother and the child live and experience together. And this experience promotes the first tie the infant makes with an external object. It's not just the mother being there, but it's the living together something. This is the crucible in which relatedness and the comprehension of external reality grows. See, that's the infant's, in Winnicott's idea, that's how the infant finds external reality. When the mother and baby are harmoniously in synchrony, there is a moment of illusion. I quote, a bit of experience which the infant can take as either his hallucination or a thing belonging to external reality. The mother does not challenge the illusion, but unobtrusively lives within the illusion and with the baby. The baby finds his or her way to reality and relatedness through living in the illusory world with the mother, and the mother enriches the illusion rather than dispelling it. Much like balanced images of primary substances and the object that is taken for granted, Winnicott tells us the object behaves according to magical laws, i.e., that means it exists when it is desired, it approaches when approached, it hurts when hurt, and lastly, it vanishes when not wanted. Hence, the analyst, like the mother, can live within the illusion unobtrusively and welcome unintegrated states, and not hurry the patient out of them into states of greater integration and relatedness. And you can see how this poses real problems for us as people. These patients are not interested in us as people, and we exist only as they need us to. You know, when we're not there or when they don't need us, we don't exist. Colin Trevathan, I don't know if any of you are familiar, he's a wonderful developmental researcher who does his own research and writes review articles of infant research in the United States. And he discusses research into the development of intersubjectivity. And he observes how mothers and infants mutually regulate and join together in what he calls a joint consciousness in companionship and cooperative intersubjectivity, such that the infant learns what it is to be a person in relation to others. He has beautiful phrases when he writes, and they fit so well together with Winnicottian thinking. He describes the vocal and the rhythmic companionship between mother and infant. The famous developmentalist Daniel Stern talks of relational emotions that anticipate contingent rhythms and sympathy from others. Trevathan talks about the rhythmic mirroring of vocal and gestural expressions, and Brazelton, that was in the early 90s, some years back, observed proto-conversations of rhythmic vocal mirroring and expressive movements. Infants, Trevathan observes, develop social awareness and meaning in purposive action, primarily by sharing and companioning with their carers. It is the sharing and being with infants in this rhythmic, vocal, and motoric registers. It's entirely grow as humans. Here, I recall, we come back to Winnicott's perspective, that reality and relatedness are gained not by intruding upon the illusion, but by living the experience together. And I would suggest that here we have the outline of an unobtrusive companioning register of psychoanalytic engagement. It is a vision that integrates the primacy of the patient's unintegrated, non-representable states, and it embraces illusion without suppressing or otherwise denuding the analyst's subjectivity. Some words on what I mean by hermeneutic regression. Relational psychoanalysis embraces the idea that when two or more people come together, new meaning is created. Primarily, Donald Stern and Donna Orange draw upon the philosophy of Hans-Georg Gadamer that embrace, and this is a philosophy that embraces the idea that meaning emerges in conversation and in connection rather from the examination and study of phenomena in a neutral scientific manner. Meaning is emergent and vibrant. It is lived rather than found. It's really a different idea. You have to find the meaning. One has to be in it with the subject rather than looking from the outside to understand it. I would suggest that regression in the treatment is a mutual and hermeneutic phenomenon. the patient and the analyst often live the new meaning together before it is clear to either what the meaning might be. The hermeneutic process is mutual and both participants surrender to it. The analyst flows with the patient into new realms of meaning and does not foreclose the process by pulling for dialogic, for verbal understanding of what is happening. I have called this process the flow of inactive engagement, a kind of lived, shared version of free association. The patient and analyst together surrender to the regressive process that emerges between them and can flow together into psychic and emotional territory that offers new and often unsurprising meaning. Rather than Freud's original metaphor in terms of free association of a solitary subject reading off the images that pass by a train window, we now have a contemporary relational metaphor of an intersubjective and shared endeavor where both participants sit side by side as they are taken by a process that they both constitute and are constituted by into realms neither could have foreseen. From this perspective, understanding and meaning emerge. They are emergent and they are lived together rather than being cognitively arrived at. A true Gadameryan conversation in which narrative is a relational event and surely a version of Trevathan's beautiful phrase, cooperative intersubjectivity. So you can see where this is headed. It's a kind of different psychoanalytic position. We find the meaning together, not from outside, but from within. So a word about the idea of total situations. Melanie Klein suggested that the infant goes through a series of total situations in the first year of life. It is in describing the infant's volatile shift into the depressive position. I'm assuming some outline of knowledge of Melanie Klein's thinking of paranoid, schizoid, and depressive position. But if you don't later, please ask about it and I'll try and clarify. In looking at the shift to the depressive position, Klein suggests that at each moment, whether flooded by depressive guilt or filled up with hope or paralyzed by overwhelming fear and paranoid schizoid fragmentation, the infant is experiencing a complete, a total situation. There is much resonance here with Winnicott's description of dissociations out of which come out of unintegration, by the way. The infant does not experience internal objects as such, so much as total situations comprising an all-engulfing experience that is mostly in the realm of primary sensations and the somatic. Klein thus suggests that regardless of the patient's reports of current and daily life, we would do well to maintain our focus on the nature of the object relationship in the transference. Quotes, for the patient is bound to deal with conflicts and anxieties re-experienced toward the analyst by the same methods he used in the past. Now, years later, in her landmark paper, Transference, the Total Situation, Betty Joseph, a British Kleinian, emphasized that the transference relationship reveals not only relationships with early objects, but also the internal world of the patient, and how that internal world is responding to the ongoing analytic relationship. Thus, the treatment relationship can be viewed as a manifestation of total situations, and there is meaning in everything that the patient brings into the relationship. The analyst is constantly to consider how the patient is, quote, using the analyst alongside what he is saying. The focus of psychoanalytic understanding is therefore shifted from the interpretation of the content of the patient's words in terms of their unconscious meaning to a more all-encompassing registration of the ongoing relationship that the patient is unconsciously creating in the analytic situation. Patients do not tell us about their internal world so much as show us in the way they relate to and use the analytic situation and the analyst. You know, Christopher Bolus, he has a very nice chapter in his book on hysteria about this, and he, in a very witty way, calls this showing off, you know, which is a nice use of the idea of people show, they don't tell. In a remarkably contemporary formulation, Betty Joseph notes that the analyst must focus on how patients convey aspects of their inner world built up from infancy, elaborated in childhood and adulthood, experiences often beyond the use of words, which we can often only capture through the feelings aroused in us, through our counter-transference. When attention is on the verbalized and formulated parts or states of the personality, the analysis may obscure less organized and non-represented manifestations of these early total situations. I would suggest that such total situations involve both the analyst, the patient, and the total field of the treatment. The patient and analyst both comprise the total situation, like the field, and we live within it. The total situation becomes incarnated in the treatment. Now, I choose this word incarnated because of the physical and somatic implication, because the word, in English at least, has the word from Latin carnated, which means flesh. It's in the body. The somatic implication, and because it captures the otherworldly, both here and now, as well as from some other time and place sense that these situations evoke for both patient and analyst. The treatment incarnates the inner worlds of illusion, where fragmentation, fantasy, the imaginary, and the liminal preside. The analyst can be unobtrusive yet deeply engaged with this process of incarnation, and the analyst can expect to live within these total situations, in altered, strange, and disturbing psychic spaces together with the patient. The task then is to flow with this process, to not impede it with precipitant interpretations or even inquiry, to companion the patient into these worlds of experience and pre-experience, where objects may be bizarre, split, or barely discernible, and where reality may take a back seat if it's present at all. The naming, alphabetizing, or understanding comes not from the realm of the verbal, although ultimately there are going to be words, right? But from joining the patient in this liminal world of illusion where the verbal is yet to set foot. Such lonely and unarticulated landscapes are best, quote, understood by the experience of being companioned in the very same register, the non-verbal. I would also echo Klein's observation that the experience of total situations is overwhelming to the infant, and the overwhelming nature of the clinical experience when one is involved in the enactment of early total situations, that is often deeply disturbing to the analyst and the patient, and can be experienced as a threat to the integrity of the treatment. These can be very intense and disturbing situations. The immersion in the paranoid schizoid experience is a totality in itself, and the lubricating creative work of the shifts between paranoid schizoid and depression are just not available. You're stuck in this paranoid schizoid world. So the work of transformation and psychic integration comes not from the flight from these paranoid schizoid total situations into verbal understanding, but from an embrace, an acceptance, and a companioning in these inchoate, in these non-verbal, non-formulated states. So now let me tell you about this case of Kyle, which hopefully captures some of these, what this looks like in a way. All right? Okay, so the case of Kyle. Kyle has taught me how to be his analyst. Entering my office for the first time 7 years ago, a tall, slightly chunky, and stylishly dressed blonde man in his 20s, with thick glasses and intense gaze, he stood in front of the couch facing me and then seemed to let his body fall into a sitting position on the couch. Right? It was just very noticeable to me. It was, and then just sort of fell onto the couch. I understood that he inhabited his body and his being in a very particular way. And I figured that his body was already telling me a story of falling, of being dropped, and that much of our work and our communication was going to be in the realm of the physical sensation and action, his and mine. His speech was very articulate and full of psychological insight. He was a very smart man. His speech came at me like a pulse, an unstoppable tsunami of word things. His words continued to come at and into me, sometimes slamming, sometimes penetrating, and sometimes caressing. Always totally physical. He told me that he was struggling with deep depression, for which he had been in therapy since he was a teenager. He had just moved to be with his boyfriend in New York City and had ended a therapy of a few years which had helped him with procrastination while he had been in graduate school in another city. In New York, he had consulted with a few therapists and had yet to find someone with whom he felt comfortable. He told me that he was struggling with powerful feelings of hopelessness and the familiar impulses to shut himself away in his apartment and withdraw from the world, something he had done repeatedly in recent years. He and his boyfriend of 7 years were fighting with increased frequency, and their sex life had dwindled to almost no contact at all. His boyfriend had become very overweight, and neither seemed to be attracted to the other anymore. He was not working and was unsure what his next move would be. The boyfriend was independently wealthy and had a prosperous career, and Kyle experienced no urgency to find his own income. Kyle knew something was very wrong with him and his life. Amidst the flow of words, I gathered that when he would withdraw into himself, he would disappear into a timeless zone, a numb haze, where he would become immersed in reading or the internet and would exist completely out of time, forgetting to wash, eat, or sleep. He would just disappear into this regressed world. Hence the procrastination of his graduate studies. At the center of his world was his mother. He would say, "She is a good person, but..." He described her total involvement and impingement on his life. Most recently, via almost constant phone contact, she and her current husband had chosen all of his graduate school courses and guided his day-to-day schedule and activities, although he attended school in another state. The relationship with the mother was laced with aggression and hatred and utter dependence. He would say, "She's a severe borderline personality disorder. It's all mood swings and tantrums." He described screaming fights. "When she flips, I flip." He said, "The thing is, I love my mother, but I need time to myself. I need to make decisions to motivate myself." When he had told her that he was in a relationship with a man, she had shown up the very next day, right? She had traveled to show up the next day to intervene and to take him home. He resisted, but some months later he was duped, cheated, into visiting home for a supposed family crisis. He said, "They trapped me." And he said, "Which was okay, I guess. My life was going nowhere." He subsequently did reunite with his boyfriend. Hopefully you get a feeling of the confusion, yes? I tried to get a grip of the narrative of his and his family's life. But as it was to become so familiar to me with Kyle, I'd become so flooded and confused that coherence was impossible. I did gather that his biological father had left his mother before he was born, that there had been some unsuccessful attempts at reunion with his father, that he had been brought up primarily by his mother and her second husband, whom he also referred to as his father, that there were two other major relationships with men in his mother's life. All of these men were referred to interchangeably as my father. His mother was one of 10 Irish-American children in a large, extended, and alcoholism-dominated family. I could not sort out who were the mother's cousins, who the siblings. All were referred to as my cousin, my uncle, and so on by Kyle. And to round things off nicely, some of them had the same names. If you've read Gabriel Garcia Marquez's 100 Years of Solitude, you remember that feeling of who is, because people have the same names. It was like that, you're lost in a labyrinth, right? Listening to all of this, I was imbibing the profound confusion that was the hallmark of his being. The closest and most meaningful relationship in his life seemed to be with his, quote, grandparents. You know, you wonder, so who are the grandparents? It took me some time to figure out that they were the parents of the biological father who had left before he was born. Kyle had made great efforts over time to visit and maintain a meaningful relationship with them. And it was very important to him. So I found myself continually confused. At first I panicked and would ask questions in a futile attempt to gain clarity. I would interrupt his flow to ask. Explanations didn't help. I learned that I had to settle into the felt world of confusion and near psychosis, and somehow to find a way to get comfortable, or at least survive and keep my own mind intact within this confusion. About a year into the treatment, he came in and he told me that his father had died of a sudden heart attack. And I felt like I was falling into a deep pit, desperately trying to figure out in my mind to grab onto something to help me. Who, in fact, had died. Right? It's a crazy, crazy moment for an analyst. For months, he became embroiled in a lawsuit. He was the only beneficiary, and there was a common law wife of the father who legally fought him and stole all the belongings from the deceased father's house. It did eventually become clear that the man who had died was his mother's first spouse, after his biological father had disappeared from the scene. And he said we had a great relationship with this father for a while. Kyle said, we'd get high on pot together. My mind would scurry for a lifetime. I was in total panic. I was thinking I needed to figure out, wait a minute, what's the timeline? Hadn't this man been in his life when he was a young boy? He's telling me they would get high together. They must have been getting high when he was what, 11, 12, 13? In fact, that was true. But, he went on, once the violence started, things were never the same, and it never stopped. It's really disorienting and crazy-making. This father had systematically terrorized him and his mother for a number of years before finally leaving. The only relief had been getting high together. He was now inheriting, because he won the lawsuit, some considerable amount from this man who caused such suffering. With nothing able to hold on to in reality other than the over-arousing intrusion, it was no surprise that he was sexually precocious and promiscuous from a very early age. He masturbated compulsively from age 7 or 8. From age 14 or so, he regularly had sex in public bathrooms with men. He describes being popular in those environments where older men would perform oral sex on him or mutually masturbate. More panic on my part, oh my God, as this world of abuse unfolded. But I did register that as he was describing sex, I felt that we had a coherent subject, a focus, and my mind could settle into a groove. Aha, an abuse narrative. It's like I'm looking for something cohesive. This was, of course, the power of sex. He and I, in these moments, could fleetingly feel oriented in a reality, in the space of the physical sexual. As an adult, his sexuality had been a zone of compulsion, psychological grounding, and mad, manic omnipotence. He told me with a sense of jaded pride, when it comes to sex and drugs, I've done everything. Outside of heroin, I've done every drug. Outside of dead bodies and children, I've done everything sexually. Indeed, he would go to great lengths to find an experience of ever-increasing arousal, defecating in a man's mouth, watching a woman have sex with a dog, beating men on their testicles until they threw up in pain, are just some of the experiences he described. He said, I feel like God. I can treat a man like a toilet. I am above the laws of reality. I can come while he throws up in pain. I am like a god. Degradation and control. No surprise. I felt coiled into this dynamic in the treatment. I drew attention to this. Was he not controlling and manipulating me, tying me up in some kind of sadomasochistic relationship? I can't recall the exact words I used, but here's the point. I would tell him that, and he would agree. He would say, of course I am. This is me. What else would I do? I'd say, can we examine this? And of course he understood already that this was what he did with people all the time, that it was what his mother and the fathers had done to him, and it was a repetition of terrible, unbearable trauma. To him, psychological insight. Of course I knew that, he would say. And he'd drop off, he'd be off on some other narrative. More words coming at me, more experience shit flowing into me. Over time, he did, however, recognize that this is why he has such difficulty in relationships. I do see how I browbeat people. I just don't listen. He did dearly want to be more of a human among humans. He became addicted, no surprise, to online sex. And online he would create a persona for himself and disappear into an illusory world with various partners. I can create myself in the persona of their ultimate fantasies, he would say. So I held on. Of course, his dysregulation of time and space infused our work. With increasing intensity. He would miss appointments and offer no explanation. He'd call in for sessions, sometime on the telephone, sometimes on time, sometimes late. On numerous occasions, I thought he had dropped out. He would miss for a week, 2 weeks. I would only to answer the phone when it rang at the time of his session, and hearing him start talking, he would not say, hello, this is Kyle, or I'm sorry, I haven't been in touch. He would just pick up from the session from where he'd left off some time ago, talking, as if no time had passed at all and nothing was wrong. I was living in a world where one is continually forgotten and where one fears that everything can be gone with no reason or warning, and where there are tears in the fabric of time. He always paid for the scheduled sessions. That's very important. The phone sessions became more bizarre and difficult for me to manage. A half hour into the session on the phone, he'd mentioned that he was driving in the car with his mother, or he had a friend sitting next to him. He'd disappear for weeks, and he would call, and only after a while mention that he was in Thailand or Indonesia with his boyfriend. No mention of whether he might have informed me. The prize goes to the session where I heard a persistent noise while we talked, and in response to my inquiry about the noise, he mentioned, oh, I'm in the shower. What country was he in? I didn't feel it really mattered at that point. One is in a totally different universe. So I tried to set some limits. More than anything else, I was struggling with the unannounced absences. I addressed the issue, and I said that treatment required a more coherent structure, that he be present and at least give notice of his upcoming movements, seemingly ordinary boundary requirements. He was furious. The treatment almost ended. He was persistent and absolutely solid in his conviction, that is your problem, not mine. This is me. I can't do this any other way, and so on. I was very affected by the rage with me. I felt deeply that I was in error to have tried to impose this structure on him. It was a break in empathy. That it was my need to take back some power, some purchase, some traction on the out-of-control feeling that permeated the treatment. I could find no other thought in my head than he was right. This was about me, what I could or would not let myself tolerate. It's so simple. Listen to the patient and be the analyst the patient needs you to be, not the analyst you think you are or that you ought to be. And I actually found this completely liberating. Was this masochism on my part or surrender? Probably a bit of both. But once I allowed the experience in and ceased trying to get him to talk about our relationship or to understand what's going on, once I allowed myself to flow with him and abandon any attempt at organizing the material, that's balance words, the treatment changed. In retrospect, I believe that his rage and insistence paradoxically provided a container for the treatment at that time and enabled me to relax my own anxieties about his absences and his dysregulation. Stephen Cooper, who's a Boston psychoanalytic, has offered insights about mutual containment in analysis. It's very smart. And I believe that here we see Kyle protecting his own treatment and containing his analyst's fears such that we and the treatment could survive in his own idiom. So the treatment deepened. And now he told me things. He had grown up, it emerged, with the persistent thought that he did not exist. Throughout his life, he felt that he was a figure in someone else's dream, and that when they would wake up, he and all the world around him would no longer exist. He had grown up playing on the edge of existence, the sexual acting out, the hyperstimulation, and he was obsessed with poisons. As a youngster, he had elaborate plans to poison everyone he knew and had actually carefully made poisonous concoctions and repeated experiences that he was not there. He said that he could differentiate what he called his dissociation from his not being there. Dissociation, for example, when faced with his father's violence, was out of fear and being overwhelmed. It was, according to him, the dissociation, soothing and sweet to dissociate, to feel nothing when beset by pain and terror. At least one is alive in order to dissociate. Most of the time, he wasn't alive. He began to open up his adolescent journals. He would bring his journals to the session. We'd look at them together. And we read his adolescent journals together. It was very, very, very moving. It was sadness and constant longing to be dead. The daily onslaught of the screaming fights in his household, and the frequent violence, an obsessive interest in the Aztecs. They, the Aztecs, feared that the sun wouldn't rise the next day, so they would make human sacrifices to the gods to be sure that the sun would indeed rise. Finally, I thought this was him. He never responded with much recognition to my comments that I now understood who he was and how he lived in this not alive twilight zone. But then, almost nothing I said ever was, even though he would harangue me for my responses to him. However, more and more there would be sessions where he would make comments such as I am talking, this is coming together. I can feel something. Of course, he was not going to take in from me. He had to find his way to the world of objects. That's balanced thought. So smart. There is much we can say about Kyle's developmental history to describe and explain his way of being in the world. Suffice to say that I believe that the failures in holding and containing, along with the annihilating intrusiveness of his mother and the environment, kept from him the experiences that would have fostered an existence. He had no object or environmental constancy, and consequently could not trust that either he or the world would exist from one moment to the next. The treatment hinged on my being able to live with him in this ongoing non-existence, and know it, and tolerate it, and expect no more. In the words of Balance, to create an environment, a climate in which the patient and analyst can tolerate the regression in a mutual experience. Sessions were often filled with news items from the press and political discussions. He wanted to know my points of view on a variety of political and historical questions. The theme of much of the discussions was power, cruelty, and domination. He wanted to know about my family background, my family history. He became very involved with the Holocaust and read voluminously. He's not Jewish. I would speak openly and honestly with him. I left the question of the analyst's self-revelation many miles behind. I understood that he needed someone to partner with, to think with, to know and be known by in a non-impinging manner. Someone with whom he could dream himself into existence, in the words of Ogden. As Winnicott's suggested, often these sessions did not appear to be anything like analysis or therapy. The crisis of the Middle East, troubles of Northern Ireland, the role of the Ukrainians in World War II, the Chavez regime in Venezuela, and so on. This is what he's talking about. And on occasion, he'd email me long essays he'd written on politics and current events, or articles that he found on the web that he wanted to engage with me and discuss them. I would be with him in these discussions and only engage with the personal relevance to him on the rare occasions when he would offer it. For instance, he commented when talking about imperialism that he understood now that his mind had been colonized by his mother's madness. Right? He found it so important. Looking back, to interpret these sessions as like resistance to analysis would have so lost him and been empathic failure on my part, you know? So generally, I was unobtrusive while being totally and intimately engaged. I'd silently make a lot of connections to myself. There's something in brackets there? No. Okay. Tracking my reverie and my thought. I've got it. Tracking, so I'd silently make connections to myself, tracking my reverie and my thought about his psychic process while engaging in these discussions with. It is okay for these kinds of extra therapy interactions, yes, but then you have to say, what does this mean? My feeling was that it was of the utmost importance that I enter these interactions as me, unadorned, no pretense, and it was equally important that they were not talked about after, unless he brought in the kind of connection such as the one I mentioned about being colonized by his mother. He was dreaming himself into existence with me. To play with the words of Thomas Ogden, I believe my unobtrusive presence provided the setting for Kyle's constitution to become evident, for his development to unfold, and for his spontaneity to develop such that he became the owner of his own sensations. I believe I would have obtruded and diverted the whole endeavor by impinging my subjectivity unbidden by him. The part of me that needed to analyze, to have good analytic sessions, to be a subject in an intersubjective relationship, or to resolve enactments. It all sounds so good, but that's not what he needed. He had never had the experience of a mother who allowed herself the reverie of primary maternal preoccupation, wherein both the mother and the infant live in a co-constructed reality that is governed by the care and responsiveness to the infant's primary needs, and wherein the mother surrenders a part of her own orientation to the real world outside of their cocoon. Winnicott tells us the mother is in a kind of psychosis. And from my work with Kyle, I can say I know what he means. As with other patients like him, he would show rather than tell. He had liposuction surgery. You know what this is? Where they suck the... Shivat Shuman. He came to my office while still healing, peels off his shirt to show me his torso, which had 4 small holes in, out of which oozed the last drops of the fat that largely had been removed. I stayed in the idiom of the treatment. We talked about the liposuction treatment, the physical feeling of discomfort, and his wishes for a leaner, thinner body. He appreciated the doctor, who helped him feel better without questioning his motives. He had not been that overweight. I had anticipated that the doctor would say, do you really need this? He was never that overweight. But the doctor went right along with him. I held my thoughts about his showing me the embodiment of the damaged container of his mind, the ruptures in his psychic skin and in his reality, and his appreciation for me, that I was now meeting him where he needed to be met. I was like the doctor. In the language of Bion, we witnessed the introduction into the treatment of beta elements, in the words of Lombardi, something more basic, more concrete and physical than what we generally mean by feelings. That's really so important. People talk about feelings. That's not what is meant by beta elements. As Lombardi suggests, this process can only emerge within and through the actual physical bodies of the patient and the analyst. I think that's so right. These elements emerging via Kyle's body in the consulting room were transformed within my reverie and in the process of talking with him in his idiom, right, talking about liposuction, into the beginnings of alpha elements of more coherent experience. So he has begun to get better. The sexual compulsivity is now a thing of the past. He's worked very hard with this. He looks back now on this and he can talk about his desperate attempts to find contact and a sense of being alive. He has enrolled in a doctoral program in his field, and although his attention and focus is still an issue, he's managing to get from one semester to the next. He ended the long-term relationship with the boyfriend, realizing himself that he felt abused and victimized by his partner's neglect and emotional abuse. He has actively impressed upon his mother and his stepfather that they must be in treatment, and although this is hard going, and there are not great resources where they don't live in New York, or there's not really great resources, but they are both in treatment, and the whole family scene has calmed down a lot. He sets much more reasonable limits with the mother and the stepfather, and he seems to appreciate how difficult it is for his mother. Right? He can understand for her also to be a human. And there's a long history of trauma and abuse of the mother, of course, which he can empathize with. Most powerfully, he says that he is now alive and talks about never having felt like a living human being among others. He did not exist before. This was most salient during the breakup with the boyfriend, which unfolded over a few years. It was very hard for them to separate. You can imagine, they left, they came back, etc. On returning to the apartment one time that they had shared to recover, to pick up his belongings, some months after he really had moved out, he found the now ex-boyfriend had morphed into another being. He was now a thin man, his face altered by cosmetic surgery, and the apartment was transformed into a black-painted sadomasochistic dungeon. As Searles would say, a non-human environment. He felt that the ex-boyfriend's metamorphosis not only veiled the boyfriend's true madness, but also served to illustrate the degree to which he, Kyle, had not existed, but had been a thing, an object, not a subject, using stimulation and perversion to construct a pretend, dress-up version of being a human being. He thanked me. He was alive, and we continue our work to this day. I offer my work with Kyle to illustrate that there are patients who can benefit from a wide range of relational practice. Total situations become incarnated in the treatment when not intruded upon by the analyst and are transformed by a mutual accompaniment rather than through interpretation and verbal understanding. The transformation happens through accompaniment. This is a technique that encompasses the ability to be unobtrusive while companioning the patient in the register and idiom that they require, that the patient requires. A technique in which unobtrusiveness is not neutrality, and in which living with and through enactments creates meaning and healing in and of itself.
Description. I don't think we have many opportunities to hear in such detail about the analyst's coexistence with patients who are so far away from the symbolic register, as you call it. There's so much to say, and I would really like...
Yeah, please ask questions. If there's no question that is too simple, if there's anything really serious, if there's anything you wanted clarification or, just for me to repeat something, it's a pleasure.
I would also say that you can ask in Hebrew, and David, who sits over there, David Kitron, volunteered to translate the questions if it is necessary. Just to warm up. I thought of what you were describing as to live an experience together, or actually it was a description of how to live a non-experience together. And I thought it was like going on being, but maybe described as going on not being. And perhaps the paradox in this phrase of going on not being hints to the hard analytic work you were doing, I think including the critical transformation you had to undergo in your attitude and in your technique. I found it really fascinating the way you describe how you shed, you say, away the regular technique.
I really like the going on not being. That really captures something, doesn't it? Because these situations are so stressful, and we can experience them as attacks on our own integrity because we so want to be psychoanalysts. We want to know things, and we want to feel our own integrity, and that we're offering the patient something. So and so often people are told, that this is resistant, that someone has to show up, or that you have to confront and deal with, what's going on here? Are you really in the treatment? Are you not in the treatment? Or For instance, with the confusion I experienced near the beginning with just how he described the family, although described is even too organized a word, because he was showing me the family in the non-symbolic register, the temptation to make a family diagram, or to ask him, oh, wait a minute, now tell me, who's the father, who was related to who, because we so want to cling to our order, and there's something about, it doesn't mean you give up yourself, but it's, feeling that you still have your own integrity and your own personhood, rather like the mother who's in primary maternal preoccupation. You are yourself, but you really are in a different zone. And to me, it's helped me. I do yoga, and it has helped because, you have this experience of being at the same time completely surrendering, but then when you're in a pose, some of you probably do yoga, right? I'm assuming. So you have the experience of being in exquisite control of every little muscles you didn't even know you had, and at the same time completely surrendering and being in another dimension. So it's this both and kind of experience that is a different kind of zone. And I think for me that helps me with this kind of situation, so that I am there but also in a very altered zone. So it's not like I'm simply anything goes, right? That's very important. Yes, that's a question.
No.
I thought maybe I would speak in Hebrew first and then, because there are such fine things, so maybe then translate it to English, with the help of the others. Just in English first, I want to thank you so much for such an enriching talk, not lecture, with us. It also meets my interest of the encounter between the potential space of Winnicott and the relational, which I belong to, the relational house, as to say. And I did it in such a personal and close way. And I want to thank you so much for it. I'm saying English, in Hebrew. I think this אני אגיד את זה קודם. החיבור בין המרחב המוניקוטיאני או האקט המוניקוטיאני וההתייחסותי הוא כל כך מעניין פה בעיניי, בגלל שאני חושבת שהמטופל חילץ ממך את הסובייקטיביות שלך. אתה רוצה דוד לתרגם באמצע? אוקיי.
Yes, I will. The combination between the Winnicottian space and the relational space is especially interesting, Orna says, because of the way it extricated from you your subjectivity.
Your inner subjectivity. Like he invited you or forced you to let go your known or comfort zone, your known language, the language which you feel comfortable with, and surrender to a different state of yourself. And this is another part of it. It is such a natural encounter between relational and Winnicott, which I love most, together, and I always feel they belong so much together. And a second thing I wanted to say is that I think we can all benefit from such an נוכחות presence. And always I feel pity for a lot of neurotic people with this definition, that we always reveal such fascinating ways in ourselves and the patients, working with the
impossible patients, with regressive patients. But why not us? Why not talk in such a way also with so-called normal people, so-called, okay?
I didn't hear that word.
So with the neurotic people, we always need the excuse to regress. Quote, it's not a regression, I think it's an enriching way of communication. What we always, I think, use this excuse in order to do something different from what we were taught to. Is it understood? Okay. Thank you.
Oh, thank you so much. Lots to talk about. I think, yeah, for me, the relational and Winnicottian thinking, it's organic. I am perplexed by people who don't see it, right? It seems because certainly in his practice, Winnicott may not have used his own experience as a contemporary person would do, but that's because he was working in the 50s and 60s in London, in post-war London, and that's okay. But the ideas of potential space, the ideas of transformation, letting yourself, using the object and so on, seem absolutely relevant, as is his developmental ideas, as I use here, and there's many more. The paper of Winnicott's that I took most from, for this paper, is Primitive Emotional Experience, which is from 1945, which is just mind-blowing, right? But there is such wisdom, really, about human relatedness, because it's about relatedness. I think it's so true, and I kind of believe passionately, the whole question about patients who are seen as not treatable, and in the current environment, at least in the United States, a lot of these difficult patients, you know, people, they get referred for much more concrete kinds of treatments, for CBT, you know, behavior therapies, and they are constrained, and people, because I think people have a great deal of tolerating who the person is. And I think, you know, actually, in the introduction, I think on the announcement, the title of my book was incorrect, and I only realized this afterwards because, and it's important because the book that I'm working on is called The Unobtrusive Relational Analyst, Working with Hard-to-Reach Patients. And either it was mistranslated or I wrote it wrong, it could be my slip, but it says difficult to treat patients. And in fact, that's really exactly the opposite of what I'm trying to say, right? Because yes, difficult, but very treatable. It's about patients that it's hard to reach. So that's, we're talking about, yes, it's difficult to reach these patients, or these parts of patients, but if we, and the issue of impossible patients gets transformed in this way. I think that, you know, there are not, the radical thing to say would be that there are not impossible patients. There are relationships between a patient and an analyst which have a limit to them, and that they can the relationship can contain or tolerate so much but not more. It's impossible to treat patients. That sort of makes it, it's all stuffed into the patient. People lead terrible lives of pain and torture in themselves, and like Kyle, terrible damage to their sense of being. And the symptomatology are almost creative ways of trying to be a human and to touch others, you know, and to feel in the world. But the impossible to treat is not in the patient, it's in the dyad, right? Either you know, and the relationship can often expand to accommodate the damage and this primitive stuff of the patient. So does that make sense? I found that a much more relaxing way to think about it, you know, and yeah.
I think that both him and you benefited so much for the difficulty to reach each other.
That's right. You know, that I benefited. I really liked Stephen Cooper's issue of mutual containment. You know, when I asked and started saying we have to get more organized, and he, like, it really almost broke the treatment. you know, he helped me, and he really helped me grow as an analyst. And it echoes something, you know, if you're familiar with the work of Harold Searles, who was writing in the 40s and 50s, working with schizophrenic, floridly psychotic people with such tenderness and empathy, and he talks about how these people who seem barely human, people on a psychotic inpatient ward who were so bizarre physically and so on, how they loved him and he loved them, and how they helped him grow and expand as a person. So there's something kind of wonderful and even joyful. It's very, to me, it's very important that psychoanalysis at some level is a joyful, life-affirming thing, that you really expand with these experiences, you know? Even when it's real pain. I mean, this was very painful, make no mistake, with Kyle.
Normal people have serious pains too.
Hi, I'd like to connect. Actually, Searles could be quite harsh with this patient because he was not ready to see them as weak, so it could be quite confrontative.
That's right.
And this is a connection to what I wanted to ask you about unobtrusiveness. And this patient, like Kyle, is both someone who has suffered an impinging mother, but seemingly also a neglecting mother. So this combination of neglect and impingement is quite a challenge for the analyst in the therapy. So when you write, it is so simple. Listen to the patient and be the analyst that the patient needs you to be. My question is, it's not whether he needs you to be. For instance, all this issue of the disappearance, where he disappeared and he was not. And the question, what is to be unobtrusive? Is it to accept anything that would go in the therapy? What about his need for you also sometimes to be worried, to be even containing in terms of putting boundaries? Is it to be obtrusive? So my question has to do with this very difficult balance between unobtrusive, meaning being accepting of everything, and where the analyst needs to give a contact of. So I'm not sure if it was a mistake when you confronted him, although both of you had to do some work afterwards, but maybe he needed you to do it, even if he was angry and even threatening. So I think it's very important because it has to do with this unobtrusiveness. What does it mean?
Yeah, no, it's very important, because unobtrusive does not simply mean that anything goes, nor does it mean that you don't attend to boundaries and that one is sort of silent, although there may be times when you are silent and really listening and listening with your body, you know. In retrospect, I think we might think of that whole episode as an enactment. And recently, and I think that makes sense to me, that it was a necessary, if you have the idea that in an analysis a necessary narrative is unfolding, that would be the hermeneutic idea, that a meaning comes to be lived together, then I think looking back, I think it's true, there was a kind of necessary story. He wasn't going to listen to me, but he needed me to stand up to him, right? He needed me to be wrong and survive, and for the relationship to survive a really abrasive and difficult moment. I think that's so. Does that make sense?
Yes, but the relational approach especially emphasizes that sometimes not reacting is an enactment.
Oh, right.
So there's no win situation.
There's no way out of enactments. The enactment is going to happen. You will be living it whether you don't choose an enactment. You're not choosing this. Like now it's sweet. No, now we're in an enactment. You will find yourself, that experience as analysts of finding yourself in something, and it may be a dense, intense enactment where something feels like it's going very wrong or suddenly became very difficult and intense, or something that is more sort of slow motion and subtle and barely visible, but you find yourself constantly being a certain way with a certain patient. You know, it's very subtle. But we don't choose that. I do think that if one is unobtrusive to letting the patient really fill the space and fill you with how they are constructed as people, you find yourself living these very interesting worlds. One of the things that I've now gotten involved in and working on, it will probably be the introduction chapter in the book, is the question of unobtrusive to what? Right? And what does that mean? And I think the primary, because it speaks to your question, I hope, is unobtrusive to the developmental needs. That's what I really mean by be the analyst the patient needs you to be. That's an exclamation of relief in this moment of discovery, really. But I think primarily it's unobtrusive to the patient's developmental needs. I made a list of 7 unobtrusive things in a coffee bar in Tel Aviv yesterday. I was thinking about this. But it's primarily unobtrusive to developmental needs. It's also unobtrusive to the developing field of the treatment. This is the idea from the Italians, Ferro and Sibi Peresi. If you have some familiarity, it comes from South America, the idea of the field of the treatment, which it's too long to explain, but you find yourself living within a relationship, a field that almost has a life of its own. And you're a part of it, but you're unobtrusive to it. I also think that to be unobtrusive to the hermeneutic dimension, which means to the meaning that is evolving, to not block it by knowing it before it's come to be. So I'm working on this. This is a very personal question for me because I'm trying to articulate what it really means, because I don't want unobtrusive to sound like, you just let anything happen. And that's also why I mentioned that he always paid for all sessions, because the part of him that was sustaining the treatment and was connected to the structure was also there. That makes a huge difference. If you're working in the clinic, there may be variations on how payment or how structure is observed. But so you understand that there was a shape to the treatment as in the same moment that it fell apart. Does that make sense?
אני מדבר בעברית. אני חושבת שזה תיאור מקרה מאוד מיוחד.
אופן משפט, בסדר?
אני חושבת שזה תיאור מקרה מאוד מיוחד.
Ofa refers to it in a very, very special case presentation. Ofa refers to it being a very special case presentation.
God, thank you. I needed to hear that part.
אבל אני רוצה להגיד דברים אחרים לגבי התיאוריה.
However, she does want to say other things in reference to the theory.
Great.
יש משהו נורא יפה לשבת ביחד ולהרגיש שכל העולם מאוחד. אבל אני חושבת שהטוטל סיטואשן של הקלניאני ומה שאתה מתאר פה לא יכולים ללכת יחד.
While it seems to be very nice to sit together in a united world, Ofa has her second thoughts whether your ideas and the total situation as described by Kleinians really fit together.
אנחנו פגשנו פה הרבה פעמים את בית דוזף, והדברים שאתה מתאר אני לא חושבת שהיו עוברים אצלה בשום צורה, כי אני חושבת שהדבר שמאוד מורגש בתיאוריה הקלניאנית, וכל כך שונה בעבודה כל כך יפה שאתה עושה פה, זה ההבדל והספרטדנס שבין המטפל והמטופל.
She has her doubts whether Betty Joseph would really approve of your approach.
מה שנקרא מקוצר ומשופר.
Now, I complete. This is a mix of some different papers to put together to give a summary. There is a paper that really only deals with the last part, the total situations part, because you can see that I am someone who I think it's true to say I have not found a psychoanalytic article from which I didn't learn something from whatever perspective, right? There's just, smart people writing, and then nobody gets paid for writing these things, right? People do this with passion and with intelligence through the history of psychoanalysis. And so Betty Joseph would be, she's not a modern Kleinian, she was a Kleinian writing, this is 60s, 70s, 80s. I find in her work just some really smart ways of understanding and hearing the patient, and the idea that this is something the patient is communicating about things that cannot be put into words by the total experience. I mean, it goes back to Melanie Klein talking about memories and feelings, right? That people communicate memories by how the feeling they create in you. That seems like a very contemporary idea. In terms of their clinical technique, they clearly are speaking from a very different, nowadays we would say a one-person situation, specifically Betty Joseph. Absolutely, if you ever read the article, Transference to Total Situation, you will see she's outside of the interaction. She interprets from outside into the patient. When the patient, in another paper, as I say, I wrote a critique of her methodology. The patient disagrees with her, and she corrects the patient, right, and shows the patient where the patient is wrong and her interpretation is right. And she absolutely does not do what I do. That's for sure.
בטי ג'וזף הייתה בארץ כמה פעמים, אז אנחנו מכירים היטב את הדברים שהיא כתבה, כי היא גם הקריאה אותם פה, ומוכרחים להגיד.
Betty Joseph has been visiting here in Israel several times, so we are quite familiar with her work.
ואין ספק, לדעתי, שביום כדי להגיד דברים יותר דומים למה שאתה אומר, לחיבור של מטפל ומטופל, היה צריך לעזוב את לונדון וללכת ללוס אנג'לס בשביל להגיד את הדברים האלה ב-1967.
In order to say the things that you are saying, with regard to the interaction, the communication between therapists and patients, one had to move away from London, or maybe to flee London to Los Angeles in 1967. Beyond had to move from London to leave London in 1967, otherwise he wouldn't have been able to do it according to offer. And maybe you as well, I'm adding.
Perhaps you can hear in the, you can hear Winnicott, you can hear Bion, you can hear the Kleinians, and hopefully you can hear the contemporary environment in which I live and breathe, which is the relational environment in New York, which is Lou Aaron, Donald Stern, Adrian Harris, Tony Bass, and so on. And it's like when I started with this, I felt like I was trying to square a circle, right? How to put together intersubjectivity, so our own subjectivity, how do we be present as ourselves and work with patients for whom there is no other, right? And it felt like doing something almost impossible. But I think it feels like there's something that makes sense, I think, hopefully. So it both works into Winnicott, but also into the relational contemporary relational world, where I think a lot of people have said that they have struggled with patients, because in the relational world, the emphasis, the contemporary field, the emphasis has been not so much on interpreting the patient's dynamics, but on speaking the analyst's subjectivity. Either inquiring how the patient feels that how my experience might be, or sharing my experience. This makes me feel this. I feel cornered or trapped, or I feel seduced, and so forth. And I think for patients who have yet to comprehend, who are pre-object related, really, to bring in your own subjectivity explicitly like that, it creates can create close treatment, or can create real fractures in treatment.
Just a technical comment. We should take another 2 minutes and then have a break. So other 2 comments. Also, I wanted to comment.
אני רציתי להגיד שזה בעיניי מה שיפה בטיפול שלך.
Also wanted to comment that this is what you find so beautiful in your case presentation.
Thank you. Is that it? Oh, yes. I just wanted to see if anyone further back, questions from students, no?
אילן רצה? מי רצה? סלים. We'll take another 5 minutes.
Well, I try to talk in English, and if it will not work, I will change it to Hebrew with the help of David. First, I want to appreciate your moving and detailed work that show what do you mean by unobtrusiveness and how do you work. But I want to ask about the interpretation, because there is I'm not sure if you mean this, probably not, but I will ask it. If interpretation is identical to obstrusiveness, or might be unobtrusive interpretation, because I can understand that mainly in most of the phase of the treatments, your patient experience any interpretation may be as an obstruction, as an obstrusive act. But as the therapy proceeds, and we can show, and we can see that it is a curious patient. He is interested in the world and what happens in the world. He is interested in politics. Might he interested in what happened to himself, and to reflect about the process, and to show, and might he interested in understanding what you think about it. That I hope it is clear that when is there a place for interpretation at all in this kind of treatment?
Thanks. It's a great question. I'm just writing this down. It's really a good question, because one needs a conversation to respond to it rather than an answer. But I'll say my thoughts just as you're speaking. And I think that we look at the value of what we say to a patient in terms of the clinical process, in terms of how the session goes. So an interpretation can be unobtrusive. That's a nice way to put it. What we want after an interpretation, after anything we say really, is to see whether the patient opens more or closes, whether the material, whether what the patient says continues or closes, right? And of course, that has to be, it's meaningful for them if they stay close to their experience and so on. So one can interpret it, and if it's right, it can be, I think, absolutely some kind of comment about the meaning and so on. Obviously, an interpretation is not just the words, but people experience an interpretation as a tender, connection, as some kind of saying, I'm with you, I'm understanding. So there's many dimensions to the speech act of interpretation. So I think you want to see where it goes, right? And last night we were mentioning that Bolus has a very good article on interpretation, transference interpretation as a resistance to free association. Thank you, Michael. Transference interpretation as a resistance to free association. And he's thinking of something that also suggests that you can, he is talking about letting the free association, letting the thing, something that is yet to be known by either party, to let it come, to let it emerge. Sometimes knowing it helps, knowing where we are, shepherds that process, like you move it along. Sometimes it stops. My concern is to bring someone like Kyle into the area of the mind and of mentalizing, because the damage for him was done in the area of physicality and so on. Does that speak to you? It speaks to it, but it's not. But it's a good. That's just a great conversation for everyone. It gets to why we say what we say. What is the effect? What are we doing when we talk? Right?
So we should take just one more comment, Celine, and then I suggest that we can continue this discussion, which is really interesting, in the next session. We should continue the discussion on the lectures of the next session and on this lecture. I think it will be a good solution.
First of all, the feeling when you read out the talk was that you talked us into existence. The words became living with experience. Very special, very different from reading your papers. Thank you.
Good.
The second part is connecting into what you said at the end, where he went back to his boyfriend and realized that his boyfriend was mad. And my feeling through your description of the case is we became mad with him. And I feel that when we are with patients like this, I work with children who are often very mad, even though they're perfectly normal, but they're very mad when they come into the play with you or play a game in a mad way. How do we know when to be mad with them? How do we know when not to be mad with them? How do we know when to say this is mad? And how does that madness, being together in the madness, become sanity?
Thank you so much. It's similar to the question before about when do you put a boundary and when do you not. And I think working with kids, last night I was talking with Yossi Tamir, who was talking about the value of working with children to really, and with disturbed children, how important that is, it can be for really confronting and engaging with these issues. And I think, to sound almost bland, really, for me personally, it is kind of like parenting, and mothering. What is the developmental need? How much is too much? Right? It's a titration. Where is allowing something to keep going, overstimulating and disorganizing? When is it companioning and when is it abandoning? Right? And like, I'm with you in this madness, but I don't want to abandon you to it. And I think, this comes down to paying careful attention to our clinical process and our sense of things. And certainly there are other cases that we don't have time for, where, around areas of real personal safety, working with the dogs, where personal safety is an issue, where there are real issues of danger. That is clearly where, the patient needs a boundary. That can't be said enough. Also, just to speak to it, right, one attends to the very, life is important and staying alive is important. And so you know, for patients who are involved with sex, in my practice, people who do sexual things that put their lives in danger, or people who seek physical stimulation by fighting, you know, and by getting into very dangerous situations. You know, one has to really, it speaks to the question before. It's not unobtrusive, because I think one begins to feel a developmental call for the containment. And it's not containment in bionic terms, but for the holding, for the boundary, for the no, just like with a child, no. No is extremely important. Winnicott talks about how no is important for the child in terms of identity, but it's an intersubjective event. No is also important from the parent for the child's identity formation. So you would know that working with damaged kids. Does that make sense?
Okay. Thank you very much, Dr. Grossman. Thank you. We shall take a break until 5 o'clock. Okay, 5 o'clock. Everything is 15 minutes removed.